So eczema is a chronic itchy skin condition which is due to inflammation. You have disturbance of the lamellar bodies, which results in a decrease in the production of lipids. When you have decrease in production of lipids, it leads to cracking of the skin. It leads to the increase in the transepidermal water loss, so water loss from the skin, and also it allows irritants to go into the skin. Eczema actually comes from the Greek word meaning to boil over. So it was years ago when scientists took a biopsy of the skin, and when they looked under the microscope, they could see the actual inflammatory cells boiling out of the skin. It's a term that's used interchangeably with dermatitis, which also means skin inflammation. But dermatitis tends to be caused by external or exogenous factors, whereas the eczema tends to be caused by endogenous factors. So some examples of the eczema, you can have seborrheic eczema, you can have atopic eczema, varicose eczema, whereas with dermatitis you can have contact irritant or contact allergic dermatitis. So atopic means that the patient has a genetic predisposition for an exaggerated IgE immune response. So how it's diagnosed is using the sign of the British Association of Dermatology guidelines. It's an itchy skin condition plus three of, first one being skin crease involvement, such as the elbows, the backs of the knees, the front of the ankles or the front of the wrists. Visible flexural eczema is the second one. Third one is dry skin within the last year. The fourth one is the personal or family history of asthma or hay fever. So, and then the last one then is onset under 2 years of age. So the distribution tends to be flexural, and in the acute stage you get erythema that's not well demarcated. You also get oedema, crusting, vesicles, papules, and whereas that with the chronic stage, so that's eczema that's gone on greater than 6 months, you tend to get more dryness, scaling, which tends to be rough on palpation. You can get fissuring, whereas you get fissuring of the earlobes, and actually coarsening, or lichenification, which is actually coarsening of the normal wrinkles of the skin. So contact dermatitis is usually due to an external allergen or an external irritant. So you've got contact irritant dermatitis. This takes up 80% of the cases. So this is where the skin is exposed to an external irritant, and the direct damage done by this is done faster than the skin can actually repair itself. It tends to happen in the hands a lot as people work with their hands, and the part of the hand that tends to be affected most is the web spaces between the fingers, whereas the thinnest, and that's the thinnest skin of your hand. Florists, beauticians, hairdressers are the occupations that tend to be affected most. So I'd always encourage to wear gloves to try and avoid the external irritant, and also plenty of emollients, and even to put on gloves at night and put the emollients on at night and put the gloves on over them might help to stop the scratching. And with the external allergic dermatitis, that's usually it's a type 4 hypersensitivity reaction. It's usually due to nickel or neomycin. So the main thing, obviously, to remove the underlying cause of it, which is the nickel or the neomycin, not to expose the patient to it. The products, there's a number of studies done, but mainly it's to emollients, and the two products that can be used is Elecon or Dormavate. In these, the studies show that it responds well to these topical corticosteroids. So seborrheic eczema is caused when the person mounts an immune response to a commensal yeast. So what the clinical picture is that the patient has got salmon pink, greasy patches, mainly on the nasolabial folds, and also on the neck and on in the scalp. It can also, in children, it tends to occur in the napkin area, which is unlike atopic atopic eczema. And it can actually in adults it also occurs on the eyelids. It can lead to inflammation on the eyelids called blepharitis. So this is the area of skin in the face that's actually the thinnest area of skin on your face. The treatment is nice oral shampoo, which is used 2 to 4 times weekly, where you leave it in contact with the scalp for 3 to 4 minutes, and then you wash it off. And also Dactocort, the hydrocortisone aspect, obviously reduce inflammation, and miconazole then to kill the commensal yeast. Okay, so the role of the topical corticosteroids in eczema depends on the severity of the eczema, and you must always take into consideration not alone the examination of the eczematous lesion, but also the effect on the eczema has on the patient's quality of life. I.e., are they itching an awful lot at night? Is this disturbing their sleep? So you've got mild potency steroid, which is hydrocortisone. Then you've moderate, which is Umavate, Modrazone, and Betnovate RD. Then you've got potent steroids, which is Betnovate, Elicon, and Locaid, and very potent then, which is Adormavate. So, and then obviously the key role here is that the patient should always be using emollients, which I'll talk about in a bit. But there's a recent enough study done, which is done by GP Practice in the UK, that showed that people that had frequent exacerbations of eczema, that if they were to be put, it's called weekend therapy. So if they were to put on the topical corticosteroid at the weekends, even when the patient is in remission, it keeps the underlying inflammation at bay within the skin, and it works very well. So the patients often ask me which is the best emollient. The best emollient is simply the one that the patient will use. Obviously, the greasier the emollient, the better, as you have better penetration and it's more occlusive, but patients don't tend to like the greasier ones as much. One way around that is that if they were to use the greasier emollients, the ointments at night, and then use the lighter creams then during the day or on their face. You also have lotions. Lotions are good for eczema that's very wet and weeping. So there's an old saying in eczema: if it's wet, you dry it, and if it's dry, you wet it. So if it's wet, you put on a lotion on it to dry the eczema, and if it's dry, you put on an ointment to moisten it. Also, if you can, I usually ask patients, would they normally put it on, or how many can they put it on? What would stop them from putting it on 2 to 4 times a day? So even if it's small, what I find good is that for them patients to put the ointments into small little containers that can go in the nappy bag or in the car or in the childminder's house or drop it into school. So it ensures that that the ointment is applied 2 to 4 times daily. Also with baths, emollient baths for them to use, and avoid all shower gels and perfume soaps and that. After the patient has a bath, which it should be done 2 or 3 times weekly, they can pat dry the skin, not to rub it too much because you'll cause more dryness and irritation. So pat it dry and then put on the emollient, which is in the direction of the hair growth. When you put it in the direction of the hair growth, it reduces the chance of folliculitis developing. So tacrolimus, or Protopic, is the main one used in Ireland, and it inhibits calcineurin phosphatase. It's used for moderate to severe eczema, and it is particularly good because it's good because it doesn't cause skin atrophy, unlike the topical corticosteroids. So the one thing I do counsel patients with is that there is a temporary burning sensation when they initially use it. So just to warn them of that, and if it happens, then to ease back on the use of it. But it's usually used twice daily for 6 weeks for an acute flare, and then twice weekly thereafter. And its use should be then reviewed after a year. So the practical advice I give would be, number one, first of all, to clip nails. Secondly, to avoid soaps and shower gels and bubble baths that will irritate and they'll strip the skin of its moisture. So, for example, to wash their hair in a sink, rather than the bubbles going, or the shower gel going on the person's skin, I would use an emollient shower gel, emollient bath oil instead of these. I would ask what would stop them from using emollients 2 to 4 times daily, which is when they should be used. And also, with the topical corticosteroids, to space it out by about an hour either side when they're putting on the topical corticosteroid. And the analogy, a lot of times people are afraid of using the topical corticosteroid. First of all, what I would talk about there is that if I use the analogy of a house being on fire. If your house is on fire, rather than rebuilding it, you have to put out the fire first. So for that, and that's what the topical corticosteroids are very good at doing. Also, when we say apply sparingly. So instead of saying apply sparingly, if what I would say is that for the adult hand, for the person, for the father or the mother's finger, for them to squeeze out the topical corticosteroid from the tip of their finger to the first crease here, right? So the distal interphalangeal joint, and that area, so in a straight line there, in that area of emollient, that amount of emollient should do the area of two hands on the child's body. Okay, so rather than a price per only, it's more practical just to say that, and they've less of a fear of it.
So at the self-appraisal, basically I'd like to know more about topical eczema treatments, as I feel there are a lot of products on the market at the moment and in the pharmacy I work, so I want to be able to counsel patients effectively on them. So the option which most accurately summarises it is managing an issue which arose during my work, and also self-reflection. And also at the time I was doing a talk on eczema, so I was teaching, tutoring, or preparing for a presentation. So the plan was that I need to look up the available topical products that we have in our pharmacy and make sure I know enough about them to counsel patients effectively. After compiling the list of meds available, I'll use resources to learn about them. I will look up the BNF, MIMS, SPC and guidelines such as NICE and SIGN, also discuss with colleagues, and it is part of my work-based training. The action I did is that I looked up the BNF, MIMS, SPC and SIGN, and also the NICE guidelines as well. Looking over my previous lecture notes, I also looked up Dermnet, as I find it a great resource. So following the best describes the formality of the activity I undertook. It's on the job learning, basically, a lot of it, and also looking at my lecture notes. So the learning I have, so emollient, so the learning that I need to document. Emollients are the mainstay of treatment in eczema, and the best emollient on the market is the one that the patient uses. So patients should be encouraged to use a range of emollients initially to see which one suits them. They should be used 2 to 4 times daily, especially immediately after bathing. The greasier the ointment is, the better it is, as it is more occlusive, but there is less patient acceptability. A lot of patients find it more acceptable to use the greasier ointments at night rather than during the day. Creams tend to be oil and water emulsions and soak into the skin more quickly. Lotions contain a higher water content than creams and are useful for wet or weeping eczema. Another important point is that the patient should wash with emollients rather than perfume soaps. The emollients are just as effective, but they do not dry the skin out as much as soaps. When there is an eczema exacerbation, a topical steroid should be used for 1 to 2 weeks. So when I'm explaining this to patients, I use a useful analogy. Is that if the patient's house is on fire, you have to put out the fire first before rebuilding it. So the steroids basically put out the fire in your skin. So a mild potency topical steroid is hydrocortisone ointment or cream. The moderate topical corticosteroids are Umivate, Betnivate RD, and Madrosone. And the potent steroids are Betnivate, Elicon, and Locaid. And a very potent steroid is Dermavate. So as there is always some inflammation occurring between exacerbations in patients with eczema, a useful technique is weekend therapy with topical corticosteroids to keep eczema in remission. So even though the patient may not have a flare-up at the time, if they put on the steroids at the weekend, it'll keep it in remission, and it's shown to reduce the amount of topical corticosteroids that patient uses in a year. So tacrolimus is a topical immunomodulator and works by inhibiting calcineurin phosphatase. It can cause temporary skin burning, which tends to subside after the first few days of usage. So it's most important to say that to patients. Its use should be reviewed after a year, as there are long-term safety concerns. So I suppose then just move on to evaluate the impact on practice. So I'm now much more confident in discussing the possible treatments for eczema and in emphasising the importance of emollient use. I always found it difficult to remember the topical steroid potencies. On reflection, I always did, and I always had to look up the BNF. But now I have a saying, or a mantra, that Umivate, Betnivate, Elicon, and Locaid. So if I say that a few times in my head, Umivate, Betnivate, Elicon, Locaid, Umivate, Betnivate, Elicon, Locaid, it allows me to learn off the potencies of all the steroids. So to explain this in more detail, by remembering that hydrocortisone is a mild potency topical corticosteroid, and Dermavate is a very potent topical corticosteroid, and Madrosone is a moderately potent steroid. The chant can be learned to know what the potency of the others on the Irish market. So Umivate, Betnivate, Elicon, and Locaid. So Umivate is a moderately potent steroid. Moderately potent steroid, and Betnivate, Elicon, and Locaid are all potent steroids. So if Betnivate is a potent steroid, then that means that Betnivate RD by deduction is a moderately potent steroid. So Umivate, Betnivate, Elicon, Locaid. Umivate is moderate, and the other three then are the potent. Now, so how is this learning and development impact my practice? Sorry, no, it's a spelling moderately. So how has this development impacted my practice? So improve performance and role, improve care for patient, address patient concerns or needs, improve my own confidence. And the competency falls under practice patient-centered care, which falls under the professional practice domain, and also the patient consultation skills, which is safe and rational use of medicines.